Thank you so much, Akshay. That was great. We'll now have Zach Strecker coming up to talk to us about developing a tablet-based mobile health surveillance technology.
Hi, everyone. My name is Zach Strecker, and over the last year, I've been developing a tablet-based mobile health surveillance system for the Madagascar Ministry of Health. With the help of Akshaya, Dr. Anu Shankar, and Dr. Christopher Golden, in collaboration with OpenSRP, we set out to create an efficient and scalable solution to the often messy process of health surveillance data collection on a national scale. In Madagascar, there is only one doctor for every 6,200 people. The total population is 25 million with 3% annual growth. This population is highly dispersed, with 80% of the population living in rural and remote communities. This presents a problem for the healthcare system, as 40% of the population lives more than 5 kilometers from a health center, and only 12% of roads in the country are paved. This significantly limits access to healthcare for some of Madagascar's most vulnerable populations. Like many developing countries, Madagascar has a severe infectious disease burden, which disproportionately affects women and children. To make matters worse, the Ministry of Health is in desperate need of a reliable communication system to coordinate with their rural healthcare facilities. This map shows districts that are underreporting malaria rapid diagnostic tests in red. The darkest districts reported less than 30% of results. These problems are only expected to worsen, with increasing cost of care, increasing poverty, and seasonal droughts and cyclones anticipated to intensify as a result of climate change. The Madagascar healthcare system has a 4-tiered system. This map shows, the top 3 levels of this system are hospitals with varying surgical capacities. However, the foundation of the healthcare system is basic health centers. This is the basic health center in Nani Bay, Madagascar, located a 12-hour walk from the nearest hospital. The primary function of this facility is to provide vaccines, education, and life-saving medications to mainly rural and remote communities. The data from basic health center consultations are compiled each month on paper and sent to the Ministry of Health. These data are then used to inform the allocation of healthcare resources and restock undersupplied facilities. As I mentioned earlier, these facilities regularly underreport their data and are out of reach to a significant portion of the population, which creates the possibility for selection bias with those most in need of healthcare underrepresented. Although basic health centers are supposed to be regularly staffed by a healthcare professional, this facility was only run for 2 days each month by this doctor. The Ministry of Health is rolling out universal healthcare coverage and plans to install 2 community health workers in every community by 2019. In order to address the communication and logistical weaknesses in its healthcare system, the ministry is looking to utilize mobile health surveillance as a potential solution. Our team has been working with the Ministry of Health and OpenSRP to develop a mobile health surveillance system called Mahari Surveillance. Our primary focus is to monitor infectious disease, non-communicable disease, maternal health, and child health. We are also evaluating local healthcare systems. So, what is OpenSRP? OpenSRP is a mobile health surveillance software currently operating in 7 countries and counting. We found this software especially useful for its cloud-based electronic record keeping and multiple levels of instantaneous communication. We adapted this software for use in Madagascar with Dr. Anu Shankar from the Harvard School of Public Health and the Summit Institute of Development based out of Indonesia. Our data collection platform is broken up into 3 separate surveys. First, we have an open census to collect demographics data and health history data. For each survey, we utilize OpenSRP's quality control features that prevent input error and also make sure that every single form is complete before submission. Next, we have our FollowUp Survey. Here we monitor symptoms of malaria, diarrheal disease, respiratory infections, pregnancy risk factors, and other healthcare problems in the country. We also look into clients' access to healthcare resources, treatment outcomes, and treatment compliance. Finally, we have our Child Health Survey. Here we collect anthropometric data to generate growth charts, which are very useful for monitoring rates of stunting. Now, as Akshaya said earlier, in Madagascar, this is especially relevant because stunting rates are up to 50% for children under the age of 5. So after the 5-week PHUS program, I stayed back in the field for 6 weeks to pilot the surveillance system. I worked with my main research assistant, Mark Gullen, and local research assistants from each community. Together, we set out to pilot Mahari surveillance in 2 research communities, Nani Bay and Taravatsu. Here we have Nani Bay, located about a 12-hour walk, like I said, from the nearest hospital and adjacent to Makira National Forest. And here we have in Taravatsu, which is about a 4-hour hike from Nani Bay. Our main objectives of the pilot program were to collect open census data from each household in both communities, train enumerators with the OpenSRP app, troubleshoot the software, and go over our surveys with Meharry doctors for comprehensiveness. The pilot program was a success. We are very satisfied with the app's performance and are now rolling out our full surveillance program in 3 communities around Intanjo Bay, in Taravatsu, Nani Bay, and Marufututra. Looking forward, we aspire to apply our surveillance program to a number of challenges, like improving the distribution of healthcare commodities by highlighting community-specific needs, providing an electronic communication system to streamline healthcare data collection, function as an early warning detection system for outbreaks of infectious disease, track the impact of climate change on human health longitudinally, assess the health impacts of natural disasters to inform programs and aid programs, quantify the benefits of health and nutrition interventions like the chicken vaccinations, and measure the effects of changes in conservation legislation and enforcement on community health. So I'd like to thank all of these groups and individuals listed for their tremendous contributions to this surveillance project. And I will leave you with a photo of my amazing research team in Taravatsu. Thank you all very much.
All right, for the past maybe 4 or 5 years, I've been working with a spoken word team in Madagascar. They're absolutely amazing group of youth in Madagascar who are really inspiring. Their linguistic and poetic abilities are really phenomenal. And I put out a call to have them produce the best planetary health spoken word piece. And this is the one that I liked the best, and so we've made a video around it. The spoken word goes very, very, very fast, so just try to keep track while you're reading, but I will be trying to make a slower version at some point.